Take it away. All right. Good afternoon, everybody. As Fred said, I'm Martha Power, and I'm the stroke coordinator here at WVU Hospital. There's a whole lot of people in this room who know a whole lot more about research than me. Shannon and I are going to really take this practical approach, kind of telling you about how to recruit and retain your patients, because that's the expertise that we have. I really want this to be interactive. Feel free to interrupt me, ask a question, share maybe things that have worked or not worked for you so others in the room can build on your experience, and we hope to help you build on ours. Just get the click on. Thank you, Megan. Okay, so today we're going to talk about building collaborative relationships. And one of the reasons that I'm standing here is I've been fortunate enough to have had some wonderful collaborative relationships with other departments, with people in the basic sciences. We've built some things in the stroke program that we hope we can share with you, and maybe you guys can use that model to build some teams that work for you in the research that you want to do. We're going to talk a little bit about patient identification, then the recruitment strategies for those patients. Shannon will go in a little more detail about the informed consent process, and then we'll talk a bit about retention of those patients that you've identified. If you're unsuccessful in any of these 5 strategies, you're likely to be unsuccessful in getting patients to the point that you get usable data and try to answer the question you're trying to answer. So it all has to come together. So building collaborative relationships. You need to identify the community that you want to work with. So when I say community, I don't just mean the Morgantown community, the community within this home of WVU and WVU Hospital. Who are the people that you want to be working with? What relationship do you have with them already? Or are they people that you've never worked with and you need to establish those relationships? I was very, very fortunate to work with Lori Gutman, and Lori Gutman really felt the value of research and pulled together an amazing team because she knew enough people in the Health Science Center, enough people on the clinical end. She had worked at NIH and had a lot of strategies that we'd not used before. And we built this amazing program where people found each other and talked to each other, whether it be a medical student, a postdoc, an attending physician, somebody in the community. There was a place to come and say, I have this idea. I'm excited about this idea. Who can help me? Help me find those people. And that's kind of what Shannon and I hope to do with you a little bit today. Encourage you to go out there and put yourself out of your comfort zone a little bit and talk to people maybe you don't know, or people who don't necessarily receive you well the first time you say, hey, I have this great idea. But encourage you to keep pushing and building those relationships. And we'll talk about what strategies we'll use to engage them before and during the study. And are there ongoing partnerships you can use? So we are very fortunate at WVU Health Science Center to have lots of partnerships, lots of great departments, lots of layers of people learning and interested. Things like this. If we look around this room, I bet there are people who want to collaborate with each other and don't even know who you are and what department you're in. So we have to just engage and talk to each other and build those relationships. So we're going to talk a little bit about the successful models of collaboration that we've had. And I encourage you to be thinking about if you currently are working with a group and have a successful model, to talk about that a little bit today when we give you the opportunity, and share with the other people in the room what you've built, because maybe they want to work with you or maybe they can just use the model that you have. So I'm going to talk a little bit about the stroke research group. So in the stroke research group, we started a regular meeting. So the first thing is people need to know you exist and come regularly. So it's Tuesday morning at 7 a.m. Who the heck wants to be there Tuesday morning at 7 a.m.? But you know what? If you make coffee and somebody bakes muffins, if you make it something that's kind of fun and collaborative, and you know, the first 10 minutes we're talking about our kids and our life and what's going on, and then we get to work, you make it something that people want to come to. They want to be a part of something and be a part of that relationship. You have to identify a champion of that group. So Lori Gutman was the champion of our group. She's now going to the University of Iowa. We didn't just give up and disband. we pulled Jim Simpkins in. Find somebody who really wants ownership, who wants it to work, who's going to stick with it. Because we all kind of float in and out as life gets crazy, right? You have this really good research interest, and this month you're on a rotation where you have enough time to give it effort. But maybe next month you're on wards, or you're on night float, or your lab is really busy and you're doing a lot of data and you don't have a lot of time. You have to have somebody who's going to be the pillar and kind of hold things up as the rest of you all float in and out. As your project is interesting, you're there and you're pulling people in, but then you might float away a little bit and somebody else floats in and their project becomes a little more of the focus. You need somebody steady to kind of be, steering the ship. Give a forum of ideas at all stages. So one of the things we did was we really said to anyone, be it a medical student, a resident, an attending, somebody in the health science center, somebody in some other department, and said, if you have an idea, we don't care if it's just an idea in your head, come and float it by this group. You don't have to come with your IRB done. That's really not what we're there for. We're there to say, that's a cool idea. Have you talked to Dr. So-and-so, or have you talked to the administrator of this other department? Or, gee, when we did a project similar to that, this is what worked, or how we found people. You need people to help guide you. I gave a talk for family medicine a month ago, and there's a student who wants to do a project we've already done. I said, great, we've already done that. That is a great idea, and we agree. How can you build on that? Here's the people who did that project. Here's their phone numbers. They can tell you what they did, how it worked. You have to keep talking to people, and don't be afraid to kind of give an idea out there that maybe isn't even going to work, but somebody can help you to say, here's what can work, here's what can't, here's the collaborative person. We had someone in the Health Science Center, Valeria, who is working on kind of a video game for stroke rehab. She had this whole idea, had this project going and was funded, and didn't know how to get stroke patients. How can you not know who the stroke nurse practitioner is if there was one in the hospital? You should be able to find that person. You got to go out of your comfort zone, call neurology, say, hey, who takes care of stroke patients? Once we met each other, she came to my stroke support group, boom, she's got 10 patients for her study. So it's just finding that right person, building those relationships. I go to a fair number of Tuesday morning 7 a.m. research meetings and listen to something that I probably understand about 10% of. That's okay. I'm going to get a little something out of that, and that person has an audience of people to say, how would you then apply that maybe to the patient later, since we're this clinical translational research group. So just kind of keep working with each other. And does anybody else here have any kind of groups like that where you come together, work on research ideas? Is there anything you can share with anybody else in the group? I think cardiology is trying to build something like this. Anybody else have where the health science and the clinical people come together? So you have a lot of work to do, Fred. But their models are there. And if you want to come Tuesday morning in Johnny Jones and listen to us, we're the second and third Tuesday of every month, and you're welcome to come sit and say, how did you people make this happen? And if you tell me, I'll make muffins or something. So let's talk about some of the incentives to collaborate. So you have this great idea. How do you get somebody to want to work with you? And it's hard because everybody's busy. There's none of us sitting around with our feet up eating bonbons, right? We're all working really hard. And so you want somebody to participate. You got to kind of make it worth their while. So it would be wonderful if we were all so altruistic that it was just to improve patient care and increase general knowledge and broaden the treatment options for our patients. But most of us kind of need some a little more incentive. Just that Tuesday morning group has been enough, that building relationships has been enough for most of us to say, geez, I really like Connie. She's a really nice person. And when she wants to approach my patients, I go in and say, hey, Connie's the research nurse that kind of works with us. She's great. She's going to tell you about this really cool project. That doesn't take any work from me. It just takes me getting the patient enthused. Who's this Connie person, and what's she going to get me involved in? And this is kind of neat. I mean, she's even getting the spouses of the patients in the studies as the age-matched normals, So you just got to kind of build that up a little bit. So sometimes it's just they got to be your friend, and it's enough that they want to work with you. It doesn't always have to be that there's some other incentive. We're going to talk about monetary incentives and that stuff a little bit later, but that gets a little bit sticky, and the ethics of that gets a little bit sticky. For a lot of us, especially in an academic medical center, just having a little bit of a CV builder is kind of nice. Getting a few publications is nice. So when you're collaborating with somebody, all the work isn't yours. That's a really nice thing. So if you work together as teams, you can help, share the writing, share the work. We have lots of people now to help us with stats and the things that are getting built here. There's lots of layers of people to help you. And if you've been to some of the other boot camps, you know how to get your fingers in some of those pies to know who all those people are that can help you. Let me go. This is just to give you an example. I said to Fred, I really wanted this to be a helpful talk and not esoteric. These are people who you can call today and say, I have a research project. Who in cardiology maybe is interested in this? So you can call Nina and say, there's an aspect of my study that has to do with cardiology. Which doc is interested in blah, blah, blah? Or who could participate with me? Emergency medicine has Steve Davis, who is a god. Interventional radiology has their research nurse, Jennifer. We are fortunate in neurology to have two. I have Jay Sherman, who's sitting right over here, and Pat is our other research coordinator. The School of Nursing, Joanne Duffy is now over research there. She could point you in the right direction because schools can collaborate with schools and we can do fabulous things. Trauma has Kim Honecker, ophthalmology, Linda Curtis. This is not a complete list. And one of the sad things was I couldn't find a complete list. So nowhere can you call at WVU and say, can you give me the name of the research coordinator for X department or X idea? So maybe that's something we need to work on in the future is how do we do that? And even do we want on one of our websites to say, hey, here's a bunch of studies that are enrolling. So maybe I have a study with TIA patients. I'm not the only one who sees TIA patients. I need my medicine colleagues to help me and send me your patients when they have TIA so I can put them in my study. But if they don't know they're happening, they're not going to help me and enroll my patients. The CTRU, I'm going to pass this to Shannon, and I'm going to give her the microphone. And she's going to talk about the collaborative relationship they have there, because that is very different and much more organized than anything else in this place.
I want to go back for just a moment and talk about one of the successful ways that we collaborate in the Cancer Center. And I apologize, my experience is specific to the Cancer Center in oncology. But one successful model that we have tumor boards. Each disease team participates in a tumor board. It's an excellent venue to discuss research opportunities. Basically, this is a group of people. They meet regularly, typically weekly, sometimes less often. And it's all the right people's in one room. For instance, your medical oncologist, your surgical oncologist, radiology, pathology, everyone's there. So we, on behalf of the breast program, I'm a study coordinator in the breast program, we utilize that venue to discuss research opportunities. We actually designate 1 week per month to devote the first 10 to 15 minutes to discussing research. So we go through our list of open trials in the breast program and we kind of just give an update on enrollment, what's going on with the trial, it's still open, don't forget we're screening patients for this, whatever trial, and these are the characteristics they need to have. But we also discuss new opportunities. So that's the point for everyone in the disease team to provide input. It's real important before, when a physician or researcher is approached about opening a clinical trial to make sure that it's vetted by your team. And I'll give you an example. We have, in the past, we participated in a neoadjuvant breast cancer trial. So neoadjuvant involves chemotherapy prior to surgery. In this case, it was early stage breast cancer. So I remember when the PI received this protocol, we looked at it. It required an extra biopsy, an extra breast biopsy. So these patients had to agree to an extra biopsy prior to starting their chemotherapy. So these are newly diagnosed breast cancer patients. So I remember looking at that protocol and talking to him, and I said, we're not going to be successful with this protocol. I fear that we're never going to get a patient on who's going to want to do this. And he's like, Shannon, it'll be okay. We have a surgeon that's engaged. She's, up and going. She's been here a little while now. She's interested in research. I said, okay, let's see. And he was right. So Hannah Hazard was our collaborator, and she definitely is a big proponent of research. So because of the teamwork that we had, she talked to every one of her patients. When she saw them as a new breast cancer diagnosis and they were eligible for this trial, she talked to every one of them before they even came to medical oncology and said, hey, listen, we have this trial. I think it's a good option for you. Here's the surgical piece of it. I'm going to have Dr. Abraham or Dr. Kurian tell you a little more about the chemotherapy piece of it. So that kind of opened their eyes to the thought of a clinical trial and the concept of it, so they weren't surprised when they walked in to see, you know, the third or fourth doctor that they've seen in the whole process. So we were very successful with that trial. We enrolled 10 patients on it. We found out once, you know, we were all on the same page, so it didn't scare them. You know, after we answered all their questions and worked through it, they're like, yeah, I'll do it, and it worked. So I had to eat humble pie on that one. But on to resources. Whoops. So we have a centralized unit, the Clinical Trials Research Unit. The director of that unit is John Name. He's here. So he would be the person, if you're really looking for centralized services or looking for some help with a project, that would be the person that you go to. So as centralized services means we offer help with regulatory, accounting, and study coordination. So accounting's pretty straightforward. That's, you know, working on a budget, you know, going back and forth with the OSP, contract, that kind of thing. Regulatory, some folks may not know what that means, but basically what they do is they help get your protocol submitted to the IRB. As many of you know, that's a lot of work, so it's great to have people help you do such things, like turn your consent form into something the IRB wants to see, ongoing continuing reviews, amendments, all those things. In addition, you know, as you do sponsored trials with industry sponsors, they have additional regulatory documents that would be required. I'm not going to go into details about that, but believe me, it's a fair amount of work. And then study coordination. So our unit, we have 2 tracks. So I'm the manager of oncology services. So over the study coordinators and data managers, Sue Collins is the manager of the Health Sciences Center division. So you may wonder, what does a study coordinator do? I don't know if you all are familiar with that concept. You may not have had the luxury of having a study coordinator. You may have done a lot of things on your own. But basically, a study coordinator, you know, the role can vary. It depends on what department you're in, what, you know, studies you're doing, what people you're working with. But they can be your right-hand man, help you identify patients. They can help you consent patients, schedule the patients for study procedures and tests. They can act as a contact for that patient to answer their question, provide symptom management. They can collect study specimens, administer questionnaires, collect data, report data to the sponsor, and so on and so forth. So a little bit about patient identification. So in the Cancer Center, I will say it's a process that's evolved over the last 10 years. I can honestly say I feel that most people, it's a part of our culture in the Cancer Center and our philosophy to consider pretty much every patient that walks through the front door a potential clinical trial participant. So it's been many years in the making, but I do feel that most people there is on that page. Now, most of them are not going to qualify for a trial, but it's good that our culture has changed to at least think of a clinical trial when we're talking to every single patient. So a few different ways to identify a patient. Of course, you know, the physician. If you are familiar with your protocols or familiar with the protocols that in which you're seeing subjects that may be eligible, you would think as you're seeing that patient of that protocol as a treatment option. That's the best way to identify patients. So you're seeing them for the first time. Okay, we have this option, and yes, we have this option, a clinical trial. Do you want to participate? I feel that it's a good option for you. So that tends to be the most successful way to identify and capture patients that are interested. The nurse coordinator, so the study coordinator, one of our roles in the Cancer Center is to also to pre-screen patients. So what that means is every day I sit at my computer for the first 20 to 30 minutes of the day, and I work with Dr. Kurian and Dr. Salkini, so I look through every single patient that they're seeing that day, and I look at their last note and some of their records to see if they might qualify for a clinical trial. What stage do they have? What's their hormone receptor status? You know, when were they diagnosed? What previous treatments have they received? So I'm pretty quick at it now. I can get through 40 patients pretty easily because of our electronic medical record system. So if I identify someone that may qualify, then I let the team know, hey, don't forget this person at 11 o'clock, they might qualify for an SABP B43, for instance, or this one might qualify for this. So call me if you think they're interested, and I'll come down. So that's typically how we function and how I work with in the breast program. Tumor board discussions, again, the clinical trial nurses attend all the tumor boards, or they should be attending all the tumor boards. So that's a good opportunity when new patients are being presented for discussion for that person or the treating physician to pipe up and say, oh yeah, another treatment option for them, a clinical trial, don't forget. So that's another way that we can capture patients.
So that's the perfect world. You hope that someday, if you're a researcher, you work in the world like the Cancer Center here, but for most of us, we don't have all those resources for research. So how are the rest of us going to identify patients? Where are your patients going to be identified? If you're a physician, is it the ER, is it inpatient, is it clinic? You might be doing research that involves the community. Who can help you identify them? So in our case, I identify a patient sometimes and Connie comes down because she sees the stroke page. You know, is there a simple thing like giving somebody a pager for if your research is on stroke pages or codes? Hey, that's easy, just carry a beeper. But usually it's a little more work than that. You need to build relationships if this is research you want to do in the community or other practice settings, and that can be a real challenge. It can be time consuming, it can be expensive. So can you utilize resources that are already there? The electronic medical record, as Shannon said, oh my goodness, is this a wealth of resource? But it's also overwhelming sometimes because you can get more than what you want, you know? So you don't want to do a search for, you know, people with a diagnosis of smoking and lung cancer and it kicks out 10,000 patients. Well, you're not going to do 10,000 chart reviews. So you have to be a little bit savvy if you're going to use the medical record to really tone down or hone down what it is that you want to get. Because chart review may be cumbersome and time consuming, right Jay? We do a fair amount of this and it can take your whole life and you don't necessarily get the benefit that you want going through that way. But you can play with Epic a little bit and they can help you. Think about businesses too. If your research is public health and in the coal mines, you're going to have to build relationships with the mines and who are the people that can help you and who's interested in health. And do you have to maybe go to NIOSH and get somebody at NIOSH that has an interest in the thing you're looking at? So think outside the box a little bit. So where will you find your subjects? So for example, let's say you're trying to do a study on people with strong religious faith. Where might you advertise? Church, right. I was in church Sunday. There was an advertisement for a dementia study in the church bulletin. You know, so you want to be thinking about where your people. Say if you want to do a study on veterans, where might you advertise? Dr. Cooper with your mouth full? VFW. There you go, exactly. The Elks Lodge, the Legion, you know, all those places. There's somebody doing research on veterans and he goes to the farmer's market and he wears a cap that says, you know, Vietnam vet. And people come up to him and talk to him and he's found other vets that way. You just got to think outside the box a little bit. The VA system itself. So you just got to really think about who's my population, who can help me, and how do I build those relationships. Doesn't it all come back to that? So recruitment, again, we talk about building those relationships. Let's talk about, actually, this is for the actual patient. Okay, so you've identified John Smith, and this is a patient you want to recruit to your study. So first you have to build a rapport with the patient. And I can tell you the mistake a lot of early researchers do that I've seen is they'll walk in and I'll say, I have a patient for your study, come on down to the ER and see them. And they say, I'm John Smith and I'm doing this research study and I want you to participate and there's really no benefit to you, but blah, 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 blah. Is that going to make you say, wow, this is exciting, I really want to help this person? No. So I can tell you the trick I get to use, because I am involved somewhat in the patient care, is I go tell them this is what we found and this is the plan, and I build this rapport and they love me because I'm going to help them and I'm going to talk them through this, and I'll see you tomorrow and I'll talk to your family. And by the way, we're looking to try to answer a difficult question in people like you, and you look them in the eye and you sit down, and all those things that you got taught about communicating with patients is true for this. Patients are going to be skeptical and you got to kind of win them over first. They have to feel that you have their best interest in heart, even if whatever you're doing has nothing to do to help them. They need to feel this connection that you care about them. If you're not directly related to their care, then find a connection. So Connie comes in the room and says, Martha Power said that I could come talk to you, and Martha's taking care of you. Yes, she is sweet, isn't she? And this is how we're going to help you. So build those relationships and use those people. I never mind. If you're doing research with me, use me. It's okay. We all kind of work together to build that rapport. And as an investigator, take ownership of introducing the option to your patient. So a patient's going to be much more likely to be involved in the study if you, as their doctor, who they know and they love and they trust, say, I want you to be a part of this. I'm going to send in my coordinator to talk to you about this. And I wish you'd be open-minded, and she'll come and blah, blah, blah. And, you know, I think this is worthwhile. I think this is okay for you to participate in. And that opens the door for people like Shannon to come in, and the patient's excited to talk to them. Shannon's going to talk a little bit more about that ownership aspect later. So what strategies will you use to recruit? Money matters, so you have to think about, it's great to use PR and media, but they don't come cheap. So if you want to put an ad in a newspaper, you might spend $500 or $1,000 for that. Are you really going to get your bang for your buck in that? Or are you better off, say, if you're looking for those deeply religious people, to go to the church bulletin, or to go to a specialist in your area that maybe sees those patients and can help you? The community outreach piece is important. It's important that whatever outreach you do, though, you tell the IRB. So that was a surprise to me when I first started doing research. We were doing heart failure research, and we found that a lot of the heart failure patients didn't come to our big academic medical center. They were being treated by their little local cardiologists. So we wanted to send a letter to the local cardiologist and say, hey, we're doing this study, we can offer this drug to your patient. But we had to first get that letter approved by the IRB. And they didn't like our wording, and we went through it several times. And so just make sure you do it right, because otherwise it will come back and get you in the end. And then we'll talk about dilution of study population a little bit. Does anybody know what that means? Nobody? Have any of you ever participated in research and been like an age match normal? Yes? Have you done it more than once? Yeah. Because people, let's say your colleagues are doing research, and so they need an age match normal. I'm doing research on people who are really stressed out, but you know, Dr. Cooper's so relaxed that I need to then, you know, use him as my age match normal. But then his other colleague in the lab next to him is doing this other study. Hey, Dr. Cooper, you were nice to Joe. Will you do my study? And then Jay says, well, I got a study too, and I hear that he's really a nice guy. People get sick of saying yes. I did my capstone project was in the middle school, and then those middle school kids were also part of the cardiac project. And then they had a student teacher who had a project, and she sent home a form. And then the parents were like, what is up with this? Are you teaching my kids, or are you experimenting on my kids? So you got to be careful about diluting the study population and too many people trying to go after the same population. Or the other thing is that you're bringing on studies like we in stroke, two different studies that work on acute stroke, and we're competing for the same patients. So you got to be really careful about what you take on, and that the population isn't already being used by somebody else and won't be available to you. So I'm going to pass this to Shannon, who is way more of an expert on informed consent than me. I think I just take it.
It's okay. So informed consent. I'm going to read this. A process by which a subject voluntarily confirms his or her willingness to participate in a particular trial after having been informed of all aspects of the trial that are relevant to the subject's decision to participate. So elements. This is a bit dry, but it's important. There are certain elements that are required to be in the informed consent form and part of the informed consent process. This is part of the Code of Federal Regulations. The basic elements that are required: purpose of research. Why are you doing the research? What are you hoping to accomplish? Any risk or discomforts? Any benefits, if there are any benefits. If there aren't, it just has to be stated as such, no benefit. Alternative treatments or procedures. The extent that the patient's records will remain confidential, if any. Voluntary compensation, which is essentially, it's for more than minimal risk trials. Will compensation be provided in the event that a subject is injured from participating in the trial? Contact information of who they can talk to for more information about the trial. Usually that's the principal investigator that's listed there and the IRB. And voluntary participation, just a fact stating that you do not have to participate in the trial. Additional elements, they're there to be there if it's applicable. If there would be unforeseen risk to a subject or an embryo or fetus, the participation may be terminated, which could be by the physician, could be by the sponsor of the trial. Are there additional costs to the subject? And it needs to be specific it should be specific as to what those additional costs may be. Are there consequences of subject's decision to withdraw? That new findings will be made available during the course of their participation. And the consent should also state the approximate number of subjects involved in a trial. So who is responsible? Well, it's a pretty easy answer. The investigator is responsible for ensuring that informed consent is obtained. They are ultimately responsible for many things involving their research project, but particularly they are responsible for ensuring that their patients or participants are adequately informed. Now, that responsibility can be delegated, but you must ensure that the person that responsibility is delegated to, that they are qualified to have this discussion and to consent patients. Do they know about the disease? Do they know, what's involved? Do they understand enough about the treatment to be able to do such things? In many instances, it's not appropriate. For instance, in the Cancer Center, our study coordinators are not listed on that consent form. We do not obtain informed consent because it's not appropriate for me as a nurse to talk to a patient about perhaps what their alternative treatments would be for a particular disease. I can talk to them about the trial and that treatment, but I can't sit there and say, well, if you don't do this, we can do this chemo and you'll have a 20% chance. And I'm not qualified to do that. So it wouldn't be appropriate for them to delegate that responsibility to me in that case. If you decide in your project that you do want to delegate that to someone who's qualified, it has to be approved by the IRB. So when you submit it to the protocol, let them know, this is who I want to be able to consent patients, and this is what their qualifications are. Of course, the study coordinator plays an important role. I said that it's not going to be delegated to me to do as a coordinator, but I certainly help with it and assist with it, meaning that I typically go in with the physician while they're talking to the patient about the specifics of the treatment, the alternatives and such, but I sometimes help fill in the gaps, maybe about the cost or, insurance coverage, or, I'm there. Sometimes I'm able to spend a little more time with them when they have questions and he's moved on to the next patient perhaps. So one thing I do want to point out is the informed consent process, it's a consent form, but the documentation shouldn't stop there. The process really should be documented in the participant's medical records. It should specifically include who consented the patient. Was it the treating physician, the PI, the nurse, whomever? Who who was in the room? Were they given enough time to read the consent and discuss participation? And that you have to make sure they have adequate time to make these decisions. And there's no risk of coercion there. You don't want anyone to think, yeah, I gave them a consent form, they signed all 30 pages, and we signed them up. So you just have to make it clear that that patient has made an informed decision. And you also need to document that you gave a copy of the consent form to the patient. So, question. How will you make yourself available when a potential subject is identified? So this one is tough. So I'm not expecting anyone to really jump up and answer because it's difficult. There's no real easy answer to this question. You know, it takes time to do research. It takes time to make sure that you're consenting your patients and giving them the information they need. It takes time. So in essence, research has to be a priority in your practice. It's going to take extra time. You have to believe that participation in that trial is a good option for the patient. I mean, certainly we talked about collaborative relationships. That can help. You know, you work with a study coordinator who can assist. You make friends with the staff so they can call you when the patient's in a room. And there's certain things you can do to help. But, you know, in essence, it's going to take more time. Yeah.
I think early notification is helpful too. If you have a 3-hour span to enroll a patient, if you can get the coordinator to let you know early, you can flex your schedule a little bit. If your clinic is full or having people that can cover you in clinics, you can get down there.
So some additional consent requirements. The consent form must be signed, it must be obtained prior to entering a subject into a study and also prior to conducting any procedures. For instance, if a trial requires a screening EKG and maybe CBC with diff be completed prior to enrollment, you have to make sure that that patient has been consented and signed that consent form prior to getting that EKG or that CBC with diff. Now, there are certain circumstances, it's particularly in oncology, where maybe a EKG was already done. You know, it was standard of care, they had one before surgery, and a CBC may have already been done. In those instances, if it's standard of care, you wouldn't necessarily have to have them sign and repeat. Some instances you do. But there are, you know, certain circumstances. But in most cases, you just have to make sure that that form is signed and it's clearly documented that their consent was obtained prior to doing anything for that particular protocol. You need to ensure that you're using the most up-to-date IRB-approved consent. So that's one thing that I can say that our electronic system has helped us with at this point. If you go right on the little brain, going to be KC site, you can print the consent form right there, and you're assured that that's the most up-to-date version. It's better practice than keeping a stack of consents in your office, because they can easily be updated and you may be unaware, and then you've asked someone to sign something that's expired. Again, we kind of talked about this. You must discuss with the patient and allow them time to read the document and ask questions, and the subject must be provided with a copy of the consent form. So I just want to point out that the process does not end after the signatures are obtained. It's an ongoing process throughout the course of their study. So as new information becomes available, that you would share that with them. And we find that patients, you know, in the beginning, they're so overwhelmed. They probably understand the general concept, but you'd be surprised there's a lot of things they think they understand, but then 2 weeks later they say something and you're like, oh, that's not what we're doing, but here, let's talk about that again. So, you know, sometimes it takes months. Some of our treatments go on for years before they really understand what's going on, and that's okay. It's just part of our role to make sure that they understand what's going on about their participation in the trial. So retention, did you want to talk about this, or I can talk about it? Okay.
So you have gotten the patient in your study. Now we got to figure out how you're going to retain them in your study. So if all you're counting on is altruism and that there are patients who really want to be playing an active part in their care, you're going to be in trouble. You've really got to keep people still engaged. Just getting early access to certain treatments for cancer patients is a real motivator. That's not necessarily true for the other disease processes, or if you're doing something that really has nothing to do with disease and is something more in the community or otherwise based. Financial incentives, you are allowed to do financial incentives to your patients, and we're going to talk a little bit more about them, but they really have to be geared toward the burden on the patient, like for travel reimbursement. You can give a fee for completion. A real incentive to a lot of people in West Virginia to participate is free health care. We take care of a fair number of patients who have no insurance, and free doctor's appointments with an expert and free testing and all of those things are a big incentive for people. That should not be the reason they do it, and you can't sell it as you should be in my study because I can give you free care. But I can tell you that is a motivator for our patients, and they come back because sometimes we're the only healthcare provider they're seeing when they're in our studies. Continuity of care is very important in a study. I was fortunate enough to do some cholesterol studies when I was a cardiology nurse practitioner that were longitudinal studies. And I was the nurse practitioner in that study for 4 or 5 years. We had a ball, and I don't know if you all know, this is my husband sitting here, but we had 3 kids during the course of that study, and these patients loved the fact that they could, you know, talk about, I remember when you were pregnant with the first one, and blah, blah, blah. They felt like they were a part of my family. You know, you build these relationships, and people just love you. We would do potlucks, and they would all come, and we'd have like a big study meeting and have a potluck dinner. You got to make it fun. You got to make it a positive experience. You have to be enthusiastic. If you walk in that clinic visit and you say, oh, I'm sorry, I didn't know you were coming, I had a full schedule, and then they scheduled you in, is that patient going to think that you're happy to see him? You know, so you got to make it like, woohoo, you're a part of my study, and I'm so glad you're here. Where's my clicker? Can you click me? There, go ahead. So you need to think about what mechanisms will you use to encourage retention. Think outside the box, make it fun. Different strategies have to be tailored to different racial and ethnic populations. So if you're doing that veterans group, how you're going to retain them might be different than another group. Say you're doing a study on a homeless population. Are they going to come to the visits, or are you going to have to go to them? How are you going to retain those people? You got to think about the group. If it's that religious group and 10 people from the same church signed up, go there. See them at their church. You know, think about ways that engages them and makes them feel important. And then think about how you're going to monitor retention. If you're in the cancer center and you have all those layers of help, God bless you. But if you're doing a study all by your lonesome, you know, how are you going to know who's coming back and keep track of all that stuff? The electronic medical record has really, really, really helped that. But, you know, you need to be thinking of this as you're planning your project. Can you go to the next one? I wanted to talk a little bit more about incentives. If you're a new researcher, you can really get in trouble if you do this wrong. So I just thought it would be important to kind of talk about this a little bit. So this is right off our website here, but payments to research subjects may be an incentive for participation or a way to reimburse the subject for travel or other experiences incurred due to participation. However, it's not considered a research benefit. You can't put that in your research form or in your consent form that that's a benefit. And you may have to take care that you don't coerce your subjects. So you really, really want to get your numbers, and you really, really want to get your project done, but be very careful. There's a very fine line between motivation and coercion. Okay. Next one. This is where that statement came off of, this website, the Responsible Conduct of Research. And this is the Office of Research Integrity and Compliance website, which you can click one more. That's the front of it, and then go ahead and go back because you can't read this. But there is an amazing amount of useful information here. I am not a researcher. You know, I'm trying to be good about this and do everything right, but there's so much I don't know. Use your helps. Don't make mistakes. Use your helps. Get on these websites. The CTRU website has a lot of good stuff. There's a lot that's being created now with people paying attention to this and trying to pull us all together and truly do clinical translational research. Use all this stuff. In the old days, I had to look through books that were this big. Your life is much better than mine. So that's basically what we have to say. I wanted to open it up first to questions, but then one other thing. Does anybody have any questions about anything we said or comments? So if there are people in this room who are doing research now and have a study that they maybe want to share with the group so that people can refer patients to you? Is there anybody that would like to mention I'm looking for age-matched normals? No? So Connie, who was sitting here, they're doing a study where they're looking for age-matched normals. I think it's 51 to 80. Do you know the upper range? And they just want to draw some blood, and they're doing a genome project. But they need blood from people who have not had a stroke who are age 51 to 80. So there are other people like that in the institution, and maybe eventually we could get something on the website so that people like you and I can go, oh, let me go help somebody, and they can take my blood. Or, you know, I did the same thing for the Cancer Center for a project they had. But, you know, help each other out, collaborate together. All right, that's all I got to say. All right, thanks for your time. Go to work.